Good evening to all the respected doctors and to all the people who have joined today. Myself, Ritul Hirve from Gloderma, and today I'll be taking the corporate presentation. So, can I proceed, doctor?
Sure, sure. Please go ahead.
Yes. So once again, welcome to all the delegates who have joined us today for Dermapath Academy and Diagnostic India Private Limited. So presents analyze real-world dermatopathology cases, histopathology, occasional support by Gloderma. So at Gloderma, our purpose is to elevate lives. Our mission goes beyond just creating products. It's about fostering changes in the lives of our customers, employees, and communities. So our core values at Gloderma is meaningful innovation, unwavering commitment to quality and safety, continuous improvement, aspirational core value, results through teamwork, and customer success above all. So these are our core values at Gloderma. So Gloderma has 7 plus first time in India products. We are having 400 plus enterprising Glodermians. Gloderma has 130th ranked pharma company in the country. We are having 700 plus distribution networks, 9,000 plus associated dermatologists who are prescribing for Gloderma. We are having a skilled research and development team, and we develop innovative formulations. So at Gloderma, we are having a variety range of different therapies. First, we are having the antifungal range. Second is the moisturizers range, acne care range, and then we are having the hair care range. Followed by psoriasis care range, topical steroids, vitiligo care, and nutraceuticals. So these are our product mix at Gloderma. So at Gloderma, patient safety is of paramount concern. India's first company to make all products which are paraben free, sulfate free, and detergent free. So presenting the first and the most flagship product of Gloderma, which is Moise, most advanced moisturizers and cleansers. So in Moise, we have different SKUs. First one is Moise LMF 48 face and body lotion. The second SKU we have is Moise Excel Hydro Boost Cream, followed by Moise Cleansing Lotion, followed by Moise Daily Moisturizing Cream, followed by Moise Skin Barrier Restoring Cream, and Moise Sindet Everyday Bathing Bar. So this is the different SKUs of Moise. The second important product that we have in Gloderma is Kivon, which is the ketoconazole range, the most advanced ketoconazole range. The advantage of solubilized ketoconazole in lipid phase. Under Kivon, we have different SKUs. First one is ketoconazole lotion 2%. Second one is Kivon soap, which is ketoconazole medicated soap, followed by Kivon zip, which is ketoconazole and zinc pyridine lotion, followed by ketoconazole tablets and ketoconazole cream. So this is our second brand, which is Kivon. The next brand that Gloderma has is MinoBoost. So, for the management of early stage androgenetic alopecia to advanced hair loss, MinoBoost complete hair regrowth therapy. In MinoBoost, we have MinoBoost 5, which contains plain minoxidil 5%, MinoBoost F5, which has minoxidil 5% and finasteride 0.1% topical solution, MinoBoost F10, which has minoxidil 10% and finasteride 0.1%, followed by MinoBoost Progain, which is minoxidil 5% and finasteride 0.1% topical solution, along with the benefits of Procapil Anagen. So this is the range of MinoBoost. Along with that, we are also having MinoBoost Score tablets, MinoBoost 2.5 mg Score tablets. So the benefit in MinoBoost is that we are having a barcode which is on the cover of the every SKU, as you can see in the screen. So with this is a patient education, information and application video, which is an initiative by Gloderma to educate the patients and to counsel the patients that how to apply the MinoBoost. The next product that we have is OZX, Ozoxacin cream and Ozoxacin. So first time in India, novel non-fluorinated topical quinolone, OZX, cream and lotion. Ozenoxacin cream is 1% and ozenoxacin lotion 2%. The next product that we have is Sanosin Baby. So Sanosin Baby is a premium pediatric skincare range. So Gloderma has done international collaboration with Mann and Schroeder Cosmetics. So we bring world-class Dermatest certified, natural and safe baby skincare products to Indian mothers. So this is an international collaboration which we have done with the leading Germany company, and we have brought Sanosin Baby. So Sanosin Baby made in Germany,
Miss Rutul, can I
Germany's
stop you for a
premium
second?
baby skincare
Sorry to
range.
interrupt.
Yes, sir.
Excuse me.
Yes, sir.
I just got messages from some delegates that they're unable to join the meeting. Can you tell me if there are people in the meeting right now? It says the meeting
All right, sir.
link,
I'll
the
just
meeting
check.
link that you've sent is not working. A few people has sent me this thing. The
Okay.
meeting link is not working. So that is, I'm just slightly worried that people may not be able to join though we have started the meeting.
All right, sir. I'll just check one minute.
Let us do that before you continue. Right. Okay. So shall we, do you have anything else to add? Do you just want to quickly finish, Ms. Ritul? Then we'll continue.
Yes, sir. I'll just finish the presentation and then it's just remaining only 4 to 5 slides more. So can
Yes.
I take?
Yes, just finished off, please. Yes.
Yes, yes, sir. So, hello everyone. Good evening again. So, we have seen about Sanosin Baby, which is Germany's premium baby skincare range. So, Sanosin Baby is having around is one globe, one formulation, 40 plus years of expertise in baby skincare, and the presence is there in around 70 plus countries. So Sanosin Baby has gained the trust and confidence of 250,000 plus Indian mothers. So Sanosin Baby has 90% natural ingredients. It is SLS and SLES, parabens, phenoxyethyl, silicones. These are around 0% in Sanosin Baby. It is original Dermatest certified product, clinically tested hypoallergenic. So Sanosin Baby is enriched with hydrolyzed milk protein and organic olive oil. In Sanosin Baby, we have Sanosin Baby bath and shampoo, Sanosin Baby care oil, Baby care soap, Sanosin Baby care cream. Then we have Sanosin Baby sun cream and care lotion. So this is the complete range of pediatric skincare under Sanosin Baby. So that's all about my presentation, sir. Thank you.
Excellent. Thank you very much. So, welcome all to this fifth CPC meeting. Ms. Ritul, if you don't mind, can you call Dr. Manoj Singh and just make sure that he attends the meeting as well, please? Just make sure he's not having any problem joining the
Yes, sir.
meeting.
Yes, sir. Yes, sir. I'll just call.
Okay. So I'm going to start off the meeting. I'm just going to share my screen. Hopefully everybody can see that. Everybody can see the screen now, right? Hopefully.
Yes.
Yes.
Okay. So we'll start off. So we've got the welcome all to the fifth Dermpath Academy CPC meeting. So we've got 7 cases this time that we need to discuss. Because it's an evening meeting, we restricted the cases to 7 instead of 9 that we had previously, which made the meeting go on to 2 hours. So hopefully we should finish relatively quickly. And it's a pleasure to have Dr. Anmol Godara, who's third year Dermat resident. Is it Dr. Anmol? Yes.
Yes, sir.
And Dr. Vinoth Kumar, who has done his DNB in pathology. These were the quiz winners from last time, and we welcome them on board to discuss the cases that we have today. We have 7 cases. So what I'll do, Dr. Anmol and Dr. Vinoth, we'll be giving you 1 case each. Maybe I'll start with you, Dr. Anmol, and then we'll
Okay,
alternate,
sir.
and you can just discuss the findings. This is completely non-confrontational. It's just informal discussion of the findings. So you can, just describe what you're seeing and give your provisional diagnosis, and then we'll see what everybody else has given, and then mark the cases accordingly. Okay?
Okay, sir.
Excellent. So Nandakumar sir, maybe you would want to take it up with Dr. Anmol. This is the first case. So this is the image, actually, case one. So the history, sorry, let us go back to the history. Let me just minimize this. So the history is a 27-year-old woman presents with a stable 4 to 5 millimeter dome-shaped skin-colored papule on the right cheek. The lesion has been present for several years. Lesion is asymptomatic with no recent change in size, color, or symptoms. Okay. That's the history, Dr. Anmol, and this is the histology. Yeah, what we normally like to do is we start with low power silhouette description, then go on to high power. On to you, Dr. Nandakumar sir.
Yeah. Can you please describe the findings at this power?
Yes, sir, this seems to be a well circumscribed dermal base nodule, and I can see some bluish, it looks like base load at low power, and there are some sebaceous glands and some empty spaces, and epidermis seems to be relatively uninvolved.
Would you like to go closer?
I can see a sebaceous gland here, the surrounding cell seems to be mature, while the surrounding peripheral cells are little less well defined. They are islands of basiloid cells, and in between there is pinky stroma. I can see a few fat lobules which are intervening in between.
And few of them contain pigment also, isn't it? Towards the upper part of the lesion.
Yes, there's pigment in this lesion.
Pigment is also seen. How are these cells arranged? What is the
So they
pattern?
are arranged in nests, I think.
Yes. They're intervened by fat spaces in between. Can we just go lower down? Is there any change in the morphology of the cells as we go to the deeper part of the lesion?
So they are not as arranged as in the nest as they are above,
Yeah.
and
Mostly they are seen scattered also, isn't it? Are we seeing any mitotic figures?
no, sir, I didn't see any significant mitotic figures or any bizarre cells.
Any nuclear atypia that we are seeing?
So cells seem relatively monomorphic and bland.
Bland. Right. So it is a lesion located in the dermis. In fact, almost throughout the thickness of the dermis, the upper part they are arranged in nests. Some of them containing brownish black pigment, apparently melanin. And the lesion is seen extending up to the lower portion of the dermis, up to the level of the sebaceous glands. Is there a clear demarcation between the lesion and the deeper dermis?
Yes, sir.
Yeah.
It seems to be cut off here.
Right. So, do we have a diagnosis or a differential diagnosis? What are we dealing with?
So I was thinking of
First of all, first of all, I know. First of all, is it an inflammatory condition or a non-inflammatory condition?
So this is a non-inflammatory condition. It is
Non-inflammatory.
circumscribed, so it is benign condition.
Right. And you think it is a benign lesion, right?
Yes.
So, what are your possibilities?
So I was thinking of intradermal levels, and then I was thinking of some appendigeal proliferation, which I'm not able to make out.
You think it is an intradermal nevus?
Yes, sir. Or the
Good.
second possibility is it could be some appendigeal proliferation because of those bluish appearance of cells that I'm not able to classify.
You would also like to think about possibility of an adnexal neoplasm. Is it so?
Yes.
Right.
But the pigment, I didn't notice in first place, so now I'm favoring intradermal levels.
Dr. Vinoth Kumar, do you have anything to add to the findings, or do you have any points to discuss?
No, sir. Actually, I also thought of like intradermal nevus only. Initially, low power, I thought of like spiroadenoma, some appendages, but like no intra tumoral lymphocytes. I mean, unable to see, and that cell morphology is also not favoring like appendageal tumor. It's more of like melanocytic.
Yeah, it looks. I mean, it's basically looks like a nevocellular lesion, isn't it?
Yes, sir. Yes.
Rather than
Appendageal.
right.
Yeah.
And the one clue is the arrangement of the cells. We find this nests of cells. That is very characteristic of a nevus. When you get this nests of cells, and that too very bland looking with very bland nuclei. So the nest of cells, which apparently shows the same kind of morphology. Sometimes it shows maturation towards the deeper portion. The cells may assume a slightly more elongated shape towards the deeper portion of the lesion, isn't it? Right.
Yes.
Yes, sir.
Sasi, can we discuss the differentials provided by the candidates?
Yes, sir. We can. One thing I just want to add, sir, in this. So the presence of fat cells, these are all fat cells, slightly higher up,
Yes.
is a clue to something. Dr. Anmol or Dr. Vinod, do you know what is the clue to presence of fat? What does
The
it mean?
regression or fibrofatty change.
Yeah, to some extent, it's basically a sign that the nevus is very old.
Yeah.
Right. And so it gives us an idea that it may be a congenital nevus, a nevus that has been there since birth, and also the fact that the nevus is tracking along the follicular sebaceous unit, along the hair follicle, sometimes can be a clue when it's going along the hair follicle. It can be a clue that it's a congenital type of nevus. So that is just a clue that I have learned from from my seniors. So just thought I'll pass it on. So let's see what everybody has marked them as for case one. So the most majority. So you've got how many participants? 33 participants, of which 13 have given intradermal nevus 1. So that will be 1. Dermal nevus is pretty much same thing. I think it's synonymous. So we are giving it 1 as well, no sir?
Yes, we can.
Dermal intradermal, we're giving it 1. So I don't know why somebody has called it a plexiform schwannoma. So
I don't think we should give credit for any other diagnosis.
Yeah. Benign compound melanocytic nevus also, unfortunately, no.
No,
Congenital melanocytic nevus, well, the history is not that of a congenital melanocytic nevus, which means something else, right, sir?
Yes.
But I don't know if you give points because they've called it a nevus and they've called it benign.
But basically, congenital melanocytic nevus is a distinct entity by itself, isn't it?
I know. Yes.
I don't think we should give any credit for that.
Yes. And then compound melanocytic nevus, they've called it nevus and benign. So either we decide to give these entities 0.25 for diagnosing a nevus.
Yeah, then in that case, both 6 and 7 will get 0.25.
0.25, I think, is reasonable enough because they called it nevus at least.
Yes.
They didn't call it something else or they didn't call it melanoma.
Yeah. Right.
Blue nevus like melanoma, unfortunately, no. Parasitoid, desmoplastic, adenoma sebaceum. Atypical, definitely not. So
No.
I think that we can't give that even though they've called it nevus. Melanocytic nevi, I didn't realize that is there in the differential. But what do you think, sir? I mean, it's not a specific diagnosis. It's there. But somebody's calling it melanocytic nevus, then
0.25 again.
Yeah, 0.25. They have to be specific because it's not, it's not a specific diagnosis. Okay. Molluscum, sebaceum, and the pigments inside. Unfortunately, no. Epidermal nevus, definitely no. Okay. So we'll finish the marking on that one. Okay. Excellent. So we'll go to case 2. Now, let me see what case 2 is. So case 2 is 30-year-old female with few erythematous scaly plaques scattered over the face and posterior trunk. Lesions healing with crusting and depigmentation is present for 2 months. Mild pruritus, erosive crusted plaques over upper and lower lips. Oral cavity has diffuse erosive ulceration over the hard palate. diffuse hair loss, and history of weight loss. So this is the case, and we've got the clinical images here as well. So we can look at them later, but let us first look at the histology. Sir, maybe I'll let you drive this entire session and I'll take over in between. Is that okay, sir? Just for simplicity.
It is fine. It is fine. As far as possible, I will. But you
Yes, sir.
certainly should.
Yes,
Can you just please read out the history once again?
Yes. So the history says 30-year-old female, few erythematous scaly plaques over the face and posterior trunk, lesions healing with crusting and pigmentation present for 2 months, mild pruritus, erosive crusted plaques over both upper and lower lips. Oral cavity shows the diffuse ulceration of the hard palate. Patient also has diffuse hair loss and weight loss.
Okay, let us see the histology.
Okay. So I think it's Dr. Vinoth's turn.
Yes.
Yeah.
Yes. Sir, in low power, I could see like epidermis, like kind of like at the junction of epidermis and the upper dermis, there is a lot of inflammation and some pigment incontinence also there.
Very good. Very good. Can we go closer?
I could see like vacuolar degeneration of the basal keratinocytes.
Mm-hmm.
Like essentially like epidermal, like parakeratosis and all not this. Of
Yeah,
maybe focal in this. Focal, it is there. Parakeratosis is there.
Yes.
And a lot of vacuolar degeneration at the junction, the basal keratinocytes.
Mm.
And the inflammatory is mostly like lymphocytic infiltrates and a lot of pigment incontinence. That's pigmented things.
Can we just move to the left-hand side? I think the infiltrate is more.
Yes.
Yeah. We're finding what is the nature of the infiltrate?
It's like lichenoid type of.
No, the type of infiltrate.
Lymphocytics mostly.
Mostly lymphocytes.
Lymphocytic, yes.
You can call it a mononuclear cell. Maybe there are plasma cells also.
Yeah, so plasma cells also there in this case. Yeah. And in this, like I thought of somewhat mucin kind of thing. Or is it due to
you mean at the edge of the section?
Yes, sir.
We will clarify with Dr. Sasi that finding. Right. So,
I think there may be some mucin here actually. This is, I think there is edema, and I think that is maybe a bit of mucin, though it's difficult to comment on this. The color of the stain is not that great, but I think this may be mucin in the interstitium all around here.
Right.
I think you're right.
Dilated.
Mostly lymphoplasmacytic infiltrate around the perivascular and in the junctions, like a type of infiltrate.
Is there any deeper component to the lesion? Are we seeing any adnexal structures?
No, sir. No, sir.
No. There are some dilated blood vessels.
Blood vessels, yes.
Right. Yeah, this I think mucin, we can definitely make out the mucin.
Internal mucin, I think.
Yeah. Whenever we find, mucin, we should be specific whether it is, uniformly distributed interstitial or around adnexal structures, etc., etc. Here, it is mostly seen interstitial.
Interstitial mucin, yes.
Interstitial mucin is there. One can confirm by doing a special stain.
Yes.
So, what would be the special stain that you would like to do? That's better stain. We can do Alcian blue also.
Okay.
So, can you just summarize the findings?
Yeah, I could see like epidermis like shows parakeratosis and.
I think it is atrophic. It is atrophic, isn't it?
Atrophic, yeah, yes, sir. It's atrophic more of.
Yeah.
Atrophic epidermis with the parakeratosis and the vacuolar degeneration of the basal keratinocytes.
Right.
And like dense lymphoplasmacytic infiltrate in the upper dermis. And with the dilated blood vessels, and it's like interstitial mucin also, along with pigment incontinence.
So we are dealing with an interface kind of pathology, isn't it?
Yes, sir.
So correlating with the history provided, what are your possibilities and how would you proceed with this?
I'm thinking of lupus,
Lupus
like because of
erythematosus.
interstitial mucin.
Presence of interstitial mucin.
Mucin and this kind of macular degeneration, that interface dermatitis.
Right.
And history is also like female.
I think you mentioned the loss of weight also.
Yes.
Right. What are the changes of cutaneous lupus erythematosus that is absent in this particular lesion that makes it interesting, isn't it? Usually histopathology of lupus erythematosus, what do you find? Skin lesion. Apart from the upper dermal change.
Adnexal involvement. Like.
Yeah, we find a deeper component in the pathology, isn't it? We find very vascular and very adnexal infiltrate. Sometimes,
very deep.
Yeah, even a touch of vasculitis may be seen. If this is cutaneous lupus erythematosus, among the different types, how will you subclassify it?
I think of discoid lupus.
Discoid lupus erythematosus.
Yes.
What else you expect in the epidermis in discoid lupus erythematosus?
I don't know.
We find the follicular plugging, that is
plugging will be there, like adnexal.
Yeah, the carpetact, it correlates with the carpetact sign that seen in clinical examination, isn't it? So that this follicular plugging would be very prominent. This atrophic epidermis with interstitial, interface involvement, lot of pigment incontinence is there. With mononuclear cells in the epidermis, presence of mucin. Yes, the first possibility would be cutaneous lupus erythematosus. And can we have a look at the clinical images?
So that's one of the images, mucosal ulceration.
Yes.
And this is not much non-specific erythematous patches on the back. And lower down, there's some crusting on these patches as well, but most of them are sun-exposed sites. These are the three pictures that I have. So erythematous scaly plugs on face and trunk. Face as well, I think you can see some lesions there.
Marked mucosal involvement is also there.
Yes.
And diffuse loss of hair.
Yes.
Weight loss.
Yes, so this is clinically a case of systemic lupus, sir. Interestingly, actually, we were having a discussion with, I was at a meeting with Dr. I.S. Reddy sir in Hyderabad, and he was asking me if we see, he said he normally fails to see mucin in lupus. And I was mentioning that I also don't see it in DLE, but often in systemic lupus, it is visible. And this case is a nice example. I don't know if he's in the meeting, and I mean, if he's watching the meeting, he normally does, he said. So this is a good example of presence of mucin in acute lupus. This is only a two acute history. I think this patient's got 2 months or something. So I don't usually see mucin in DLE. Mucin is not a common finding for me, but definitely subacute and acute lupus, we do tend to see mucin. What is your feeling, sir?
Yeah, I agree. We do not see much of mucin, or mucin is mostly absent in full-blown cases of discoid lupus erythematosus. We make the diagnosis based on the typical histology, epidermis as well as in the dermis. But
often there is basement membrane thickening as well in DLE,
yes,
right?
we can do a PA stain to look at the basement membrane. It's a very useful histochemical stain. This would be I wouldn't call this as discoid lupus erythematosus per se. But what do you say, Dr. Sasi?
No, definitely not discoid.
Discoid lupus erythematosus. It is not discoid lupus erythematosus. Cutaneous lupus erythematosus. Perhaps, how do we differentiate? I mean, just for academic discussion, how do we differentiate histology-wise the subacute from discoid lupus erythematosus? Can we differentiate?
Discoid will have that basement membrane thickening usually.
Yeah.
And then follicular plugging will be there.
And I think in
What
acute, the acute thing will have. I think one of the learning points from here, maybe in the acute, you don't have that much of follicular and
correct,
deeper involvement, because in acute
correct,
insult,
correct,
most of the inflammation is probably restricted to the superficial
correct, correct.
dermis.
The full-blown picture of discoid lupus erythematosus will not be seen in acute and subacute, whereas it will be more of the inflammatory component will be more here, along with the presence of mucin. Any differential diagnosis that we should consider once we see the mucin? I think we need not really.
Yeah, I think the differential is with the CPC. I think there's no differential, sir. I think this is a clear shut
Yeah.
case.
Yes.
Personally, let's look at the diagnosis, what everyone is giving. So only 9 have called it systemic lupus. So we're giving them 1. Discoid lupus, I mean, they've called it lupus. So are we giving them 0.25, 0.5? What do you think, sir?
0.5.
0.5 is okay for discoid lupus because they've called it lupus at least.
Yes.
Subacute cutaneous also, probably the history is not of subacute cutaneous. Normally, subacute cutaneous should be a bit more deeper infiltrate. History is also of SLE. So I don't know. What do you think, sir?
0.5.
0.5 for that too. Yes. Erosive lichen planus. Histologically, it's differential.
No, we cannot. With the history and the presence of mucin.
Yes. Paraneoplastic pemphigus is an interesting differential, but there's no sign of pemphigus here. What do you say? I don't think so.
We cannot give any credit for that. It is good to think about paraneoplastic pemphigus, but we cannot offer a diagnosis of paraneoplastic pemphigus with this histology.
Yes, absolutely. So the only other thing we can consider is fixed drug eruption is an interesting differential for the histology, but the presence of mucin and the history is not that of fixed drug eruption. So I don't think it's just a lichenoid eruption. I think that's as far as the overlap goes. So no marks for that. I don't think so.
FD, the findings are more subtle. We do not see this kind of a florid interface change.
Yes.
It's more subtle.
And LE-EM-like syndrome, again, there is no change or suggest to EM. I think that is a misdiagnosis. So I don't think we should be giving any marks at all, even though LE is mentioned, because they have actually gone into something else. What do you think, sir?
I think person has gone too far.
Yeah. Pleva, again, the parakeratosis made them maybe think about pleva, but there is no infiltrate into the epidermis and there's not much spongiosis. So no, not the clinical, with the clinical history, definitely not pleva.
No extravasant RB is nothing.
Yeah. Drug eruption, I guess anything can be called drug eruption. So I don't think so.
We cannot.
So I think we'll submit the results here. I think that should do. So Dr. Anmol and both of you can interject if you feel that you want some things to give an answer.
Sir, I had a query in this case.
Please go ahead.
Sir, in that top right epidermis, I was seeing few viral cytopathic effects.
Okay, let me see what you were confused by, and then we'll see. Okay, you can maybe look at the slide. So please feel free to ask when we are discussing the slide. Please feel free. Don't worry.
This is
just focus in. Sir, do you feel these are like coelocytic changes and viral cytopathic effect changes, or are these just secondary to inflammation here? I mean, the pattern is of lupus, but are these incidental findings or this is superimposed viral infection?
This is just spongiosis. Can you see the spongiotic desmosomes? You can see the desmosomes stretching them across. So when there is so much spongiosis and a lot of inflammation, there will be a slight amount of disc keratosis, which is part of any lichenoid inflammatory reaction. Okay? So these are not coelocytes by any means.
And this is not
the bottom of the screen I'm talking about. If you see a little left of the spongiosis. A little below this.
Here we don't even have epidermis. The basal layer is eaten away and stops there. Where do you can maybe tell me you can see my pointer, right?
Sir, in the bottom left corner.
Bottom left corner, you're talking about these ones?
Yes, sir.
No, unfortunately, this is just a slightly dyskeratotic cell. The coelocytes look completely different.
They are not coelocytes.
So when there is so much, this is a beautiful. What is this? What I'm pointing at? Nice Star-shaped.
Oh,
This is a mitotic figure, right?
mitotic figure, sir. Yes, sir.
Yeah. So you can see diskeratosis, you can see one mitotic figure doesn't make it malignant, and diskeratotic cells don't make it coilocytosis. Okay. So yeah, it's a good thing to point out because it's very easy as a junior when you're not seen enough cases to get confused. And I've been through that stage. I know exactly what you mean, but it's extremely good that you got that clarified because I'm sure a lot of viewers who are viewing this would also get the same doubt. And you've given us an opportunity to clarify that. Anything else that you wanted to discuss?
No, sir. Thank you.
Okay, excellent, excellent. So we'll go back to move to case 3. Sorry, I have to go to the history. So it says erythematous fleshy nodule on the foot, slow growing since 5 years. Query what? That is the clinical history. So that is the lesion, and I think Dr. Anmol's turn, and Nandakumar sir, you can take over. I will discuss this section because this is more clearer than the other one.
Yes, yeah, on the right-hand side.
So at low power, I can see that there is ulceration in epidermis, and there are downward projection of epidermis coming, which are looking at acanthotic, and there is uh, dense inflammation surrounding these epidermal projections, and there are few empty spaces in the epidermis which I can see, and there seems to be some pinkish material also in these empty spaces.
Is it only acanthosis?
So there seems to be invagination, like endophytic. I felt it was endophytic.
We will just go closer. We will just go closer. Is it acanthotic epidermis or something else?
Sir, I was a little confused, but I felt it is. Or I also means I felt the cells. These were like a little smaller and more
Yeah.
cuboidal. So I was thinking of poroma like.
Do they look like, keratinocytes? Are they
No,
keratinocytes?
I was also thinking of these are looking at like poroid cells. At some edges, there are like normal epidermal cells, and at some places they are smaller and more uh, bluish, and
They're even
they're not
thin.
looking like normal keratinocytes. And I was also thinking of there are at few places I felt there are some ductal formation or with some
This is
material.
Yeah, these are the cells, isn't it? They are not. They are
Yes.
not. They do not look like normal epidermal cells or keratinocytes. So what do they look like?
So they look like
You've already said
poroid
it.
cells.
You already said it.
Poroid
Cells.
cells.
Do you want to qualify what do you mean by poroid so that people will understand what is poroid and how is it different from keratinocyte?
The poroid cells they usually have smaller cuboidal and basophilic, more basophilic nucleus, but with ample eosinophilic cytoplasm, and they usually present with a transition zone to normal epidermal cells, and they usually are interconnected and form interlacing or branching pattern. They usually come from the acrine pore of the sweat duct.
So I think the first learning point is do not commit on something just by seeing the scanner view, isn't it, Dr. Anmol?
Yes, sir.
Right. In scanner view, it apparently looks like acanthosis. I do agree.
Yes, sir.
But
I could not find any better term for it.
Yeah, once you go closer, it is not. So what is the lesion?
So you can call it an epidermal proliferation, Dr. Anmol. Instead of calling it acanthosis, you would say the epidermis, there is the tumor in the epidermis. Or you can say there is the epidermal proliferation, which is invaginating into the dermis, rather than acanthosis. That's a better term.
Okay.
Go ahead.
At the top of the lesion, you can see the normal keratinocytes just beneath the area of ulceration. Here.
Yes, sir.
Here we can see the keratinocytes. So, as Dr. Sasi rightly said, better to describe it that the epidermis is proliferated and is composed of those kind of cells. And then you describe the cells. So once you describe the cells, you have got the diagnosis. So what is
So,
your
Dr. Anmol,
diagnosis?
what is the other thing that is different between how do you differentiate these? Why are we calling these keratinocytes and why are we calling those poroid? What is the difference?
So
What
they
are we
are
seeing here?
having these spiny projections.
Desmosomes, right?
Desmosome. Yes.
And also the cells are more pentagonal sometimes. There the cells are nice and rounded, right?
Yes, sir.
In poroid cells are nice and rounded. For example, here they're nice and rounded. These are poroid cells. And then these become keratinocytes. You can see the transition here, as you said.
Even the intercellular bridges are very prominent. We can see that
Yes.
towards the upper portion of the.
I mean, it's a beautiful case if somebody is looking to understand what poroid means. This is what we mean by poroid. And poroid doesn't mean the cells look like a pore. It looks like they arise from the pore. And the nice rounded cells like these, very monomorphic, in contrast to keratinocytes, which show a maturation from columnar to cuboidal to flattened cells as we go up. These cells don't show any maturation. They're nice, uniform, and rounded. And they are present and they replace the keratinocytes. And that's an excellent example of it. If somebody is wanting to understand what poroid means, you can see the nice transition from poroid to keratinocytes. Okay,
A good
go ahead, sir.
case.
So next we have to, I guess, decide, sir, whether it's malignant or not.
Yeah, yes. There are few mitotic figures, but I think I would call it as only as benign.
Yes. Wonder what Dr. Anmol thinks.
Sir, overall, the lesion was not infiltrating. It was very well delineated from the underlying tissue, and some mitosis, I think it is normal in all these epidermal lesions, especially which looks basaloid. And the history was also not very suggestive of any malignant lesion. And I feel these are benign.
Yeah. So, what about anything like an intradermal in situ poroma, porocarcinoma? Would you discount that completely? It's a lesion is ulcerated. Is it common for a poroma to become ulcerated? Because ulceration, some people consider as a sign of malignancy sometimes, and is that something that we need to be worried about?
So poroma usually they're on feet, and that is commonly friction-prone site. So ulceration is pretty common in poromas.
Mm. And you can see here the ulceration is not due to the poroid cells infiltrating itself. They're keratinocytes at the top anyway. So it's probably just because the poroid cells have, replaced them to some extent. They're not present right on the surface. I did consider the atypia. I've called it, it's slightly atypical but benign. There are some features of atypia, as Dr. Nandakumar sir said. So I mentioned that there are a few mitotic figures, but they look normal. And there is inflammation as well, lots of inflammation. And with ulceration and inflammation, you're bound to see some mitotic figures, etc. So that's okay. So I called this a benign poroma. Okay. Anything else you want to discuss, sir, or any doubts from the
No,
other?
this particular patient needs to be followed up.
Absolutely. No. We
With that,
advise
that's it.
excision.
Yeah.
Yes,
We should
yes.
advise complete excision and follow up.
Because one of the reasons advise excision is 62-year-old male. So at that age, we don't want any lesions that are hanging about.
These adnexal tumors are sometimes very tricky. We cannot really decide whether it is benign or malignant by looking at the
Yes.
histology alone.
Yes.
We have to be clear in what we sign off as the report. In this case,
Yes.
a follow-up and complete excision should be advised.
Yes. So I think we're giving full marks to equine poroma. Only 7 out of 33 have called it. Somebody's called Bowen's. Apocrine poroma, I don't think so. I mean, they call it poroma, but it's fine. But where do you find apocrine glands on the foot? I mean, that's.
No.
Are we giving it any marks?
No, we cannot, especially with the history given. No, we cannot.
Yeah. I mean, apocrine poromas are different. I mean, it is a poroma though. Shall we give it 0.25? Because they've identified the poroid cells.
Okay, 0.25.
0.25, be a bit generous, encourage them a bit. Acanthotic SEBK is a good differential, but SEBK on the foot is really a wrong diagnosis. I've never seen a seborrheic keratosis on the foot, and that too with poroid cells. I don't think we can consider any other differentials here at all. Bovinoid pogocarcinoma. I've never heard that. I guess they mean in situ, but I don't think that's we can give any marks for carcinoma. Atypical head neck cell tumor is very vague. So I think we'll submit it as it is, sir. Yes?
Yes. I think somebody has called it as basal cell carcinoma. We shouldn't get confused. This is not
Yes,
basal
yes.
cell carcinoma. Somebody has called it as
Yes,
basal
basal
cell
cell,
carcinoma.
squamous cell, lichenoid keratosis.
Yes.
I don't know where they got all this, but anyway, keratoacanthoma also in the differential accessory digit. I don't know how they got
Yeah.
that. Okay, anyway.
So that's a, good case to study the lesion, poroma.
Absolutely. So after this quiz, everybody who's registered will have access to the module. So I encourage you to please go back and look at the image closely. All these images, all the previous modules, you have access to all the modules, all the images, and you have access to the discussion also. Please go through. The more you go through and the more you learn. I mean, the more you look at the lesion speaks a lot, and you don't need any teacher. The lesion teaches you. It's a beautiful case, this one. So this is the next case. 30-year-old woman presents with a 1.5 centimeter slowly enlarging painless nodule on the flexor aspect of the forearm for 1 year. Lesion is firm, well-defined and mobile with slight tenderness on percussion. No sensory or motor deficit, no prior trauma, no other similar nodules or no family history of similar lesions. So 1.5 centimeters, slowly enlarging, painless nodule, single nodule, okay? Firm, well-defined, mobile, slight tenderness. So whose turn is it now? I guess
Vinoth Kumar.
Yes.
Okay.
So here I could see the like in the low power dermal proliferation, like dermal nodules are there. Like in the epidermis is like uninvolved by that.
Let's go closer.
Higher power, I could see the nodules of like mostly spindle cell lesion, and I could find some typical like verrucate bodies and like Antony area and P areas. And the cells are showing like some ancient changes also in some of the nodules. Pedo here. The degenerative changes are there. I couldn't find mitosis or like any atypical cells.
Very good section. Very good section, actually.
Yes.
For beginners in dermatopathology to learn this lesion. A beautiful slide.
Do you have anything to add, sir?
No, the cells looks bland. Whenever we are describing, you describe the nodules, right? Then you should
Yes.
describe the pattern.
Cells. Yes.
The pattern in which the cells are arranged. Whether there is a whirling arrangement is there.
Yes, sir.
Such things can be mentioned.
Well circumscribed nodules, sir, actually, and then showing mostly spindle cells. Like bland spindle cells,
and then we should describe about the nucleus.
Yeah.
What is the shape of the nucleus? Whether there is pleomorphism, whether there is mitotic figures, whether there is nucleolus is there. Because this is maybe this is a straightforward case, but all spindle cell lesions occurring in the skin are not as straightforward as this.
Yes.
Sometimes you may be mistaken, right?
Yes.
So this is a benign spindle cell lesion.
Yes.
Can you just give me a list of benign spindle cell lesions occurring in the skin?
Schwannoma.
Neurofibroma.
And then
what about leiomyoma?
Leiomyoma, yes.
Leiomyoma. Isn't it?
Yes.
Sasi mentioned about slightly painful lesion. Which are the nodular lesions that occur on the skin which is painful or tender?
Glomus tumor.
A glomus tumor, yeah. Very good. So this is not a glomus tumor, obviously.
No.
So this is
benign spindle cell lesion.
Lesion consistent with
Schwannoma, sir. Some ancient changes are there. So like ancient schwannomas.
So, to call it as ancient schwannoma, I think I need more of
changes.
Changes.
In one of the below only, like it's like more changes are there. Remaining adult glands.
I would call it as schwannoma. So benign spindle cell lesion consisting with schwannoma.
Yes.
Which INC marker can be advised to confirm?
S100 we can.
We can do an S100 and we can do a proliferation marker also.
Like mitotic K67.
Yeah, K67.
So, Dr. Vinoth, do you want to to specify what made you think of a schwannoma? What are the exact diagnostic features?
Sir, it's like well circumscribed and benign spindle cell lesion, sir, and I could find some like typical that Antony A and Antony B areas, like arrangement of the cells.
Can you, for people who don't know what Antony A and Antony B are, can you maybe specify?
Actually, like hypocellular and hypercellular, and arrangement of cells like towards and this thing.
What is this called?
Antony A. Verruca bodies, like
Verruca bodies, yes.
Bodies in between, yes.
Yes. And this is Antony B, which are less spindle cell, more rounded, right?
Yes.
And these are more spindly and pointing towards one direction, arranged in one direction. Yes. So that's a typical feature of this entity. Okay. Shall we move on, sir? Do you have anything else to discuss? Shall we go to the...
Just concentrate on the shape of the nucleus. That will tell you that it is a neural origin. The pointed end of the nucleus, which may even show what is textbook description buckling. It may just bend at the end. Unlike the cells of the leiomyoma, which would be more blunt-ended. Here it is very pointed, right?
This one, sir?
Yes.
Yeah, yes. That's all.
And here as well.
Yeah. That's what is called as buckling of the nucleus.
I've not heard this term, sir, so it's I've learned something new. Though I've noticed it, this is not something I've learned.
It is a clue that we are dealing with a neural lesion.
Okay, that's good. Okay. So we'll go to the results. So we'll see what everybody has answered. Case number 4. We've got 3 more cases after this. So plexiform schwannoma. Okay. Let us first ask the guests here, Dr. Anmol and Dr. Nitin, what about plexiform schwannoma? Do you think that's the right diagnosis here?
I don't think so, sir. Like it's a single nodule.
Single nodule, right? So I guess people called it plexiform because they thought that nodules are histologically in a... Yeah. I think that's where they got confused with plexiform. Plexiform is more of a clinical description, right?
Yes.
Right.
And I'm glad, Dr. Vinoth, you got that as a pathologist because I guess it's easily confused, and that's a very good point. So shall we give them any marks for calling it schwannoma, sir? 0.5?
Yeah, we're 0.5.
0.5, yes. And then neurofibroma, unfortunately not.
No.
Schwannoma, neurolemoma is synonyms. So yes, so that's the same thing. So that gets 1 mark. That is the main diagnosis, schwannoma, neurolemoma. Spindle cell tumor is too non-specific. I don't think I'm personally going to give anything at all because if we do that, then we have to give it for leiomyoma as well. And
we won't.
Yeah.
So see, this is what I said. The DDs comes, leiomyoma, things like that comes.
Somebody has mentioned histoid Hansen's. I guess why they're confused is because it seems like it's curvy in here, and I can understand that, but unfortunately, that's not it. Hyalonizing spindle cell tumor rosettes. There's no rosettes here. Neurofibroma atypia, epithelioid neurofibroma. Again, the clue here is the Antony A and Antony B areas. So we cannot give anything. Segmental neurofibromatosis, that cannot be differential given the clinical. Neuroma, palisaded, and these are all completely different entities.
Neurolemoma.
It's the same thing, yes. So that, okay. I didn't realize that's in the list. Okay. So intraneural perineuroma. I don't know where they got that from. This is not an intraneural perineuroma. Myxoid neurofibroma. Ancient schwannoma, is that Maybe
we'll
Dr.
give
Vinoth, you
0.5.
thought that. Yeah,
0.5.
0.5 for that. Yeah. Okay. So we have submitted that. Excellent. So got three more cases to discuss and about half an hour to quickly discuss them. These are easier cases, so I think it's easy. Dr. Anmol, you can maybe take this now. So 38-year-old man presents with a 3 to 4 week history of persistent low-grade fever, weight loss, and severe fatigue. Reports multiple tiny umbilical or papillonodular lesions appearing on his face and upper trunk, some of which resemble molluscum contagiosum. He also notes a chronic non-productive cough and reduced appetite. Several courses of topical antibiotics and antifungals from local practitioners produced no improvement. He denies outdoor travel or exposure to birds and bats. And I mean, if you see this, you have seen it. If you don't know it, you don't know it. It's a very classical case. I don't think low power can help you in this case, unfortunately, but it will help us narrow down some differentials.
Sir, at low power, I was only able to identify there is a lot of inflammation and the whole of the dermis is involved.
Can we
And
just rotate the image? Bring
and
the
there seems to be
yeah.
epidermis
Yes.
seems to be cut off.
The massive infiltrate in the dermis, isn't it?
Yes, sir. Almost
So I
all of
guess
that dermis is involved.
I guess there are some differentials we can narrow down, right? You've ruled out all the epidermal disorders. You've ruled out all the spongiotic, lichenoid, psoriasiform. You've ruled out vasculopathies. You ruled out panicleitis. So you're down to what group of diseases are you dealing with based on the low power?
So probably infectious disease.
Probably infectious granulomatous disease or infectious disease, right? I mean,
Yes.
low power, you don't see the granulomas as such, but then, yes, you never know. Or then infiltrative disease as well, maybe, because it's so dense inflammation. We don't see the cellular structure on low power, but infiltrative disease also perhaps possible. And then the clue is already there. I mean, it's a beautiful case. Dr. Manoj Singh's case is, I think this is.
Oh, it's too many.
Yeah.
So this is full of small organisms, and these are both intracellular within these sites, and also some extracellular organisms are there. And there seems to be some sort of halo, which is probably capsule around them.
Not zooming here, but yes, I agree.
Yeah, I think here the halo is nicely seen, just above the here in that area.
Yes, here it is there.
So the diagnosis.
So sir, I was confused between histo and crypto, but I watched the first CPC in which sir was saying the extracellular is suggestive of cryptococcosis, so I am going with cryptococcosis. Histoplasmosis is should be mainly intracellular, and cryptococcosis is in extracellular and intracellular as well.
Okay. Should we use that as a hard and fast rule? I guess that's the question. These are all just clues, but may
I
not
was
always.
confused. Yeah, I was confused in between these two of them.
Yeah. Okay. I think it's difficult, isn't it, sir? What do you think?
On morphology alone, we cannot always differentiate between the two. But to
From
me,
size, sir, it was a little smaller than cryptococcosis. It was looking more like
yes,
histoplasmosis from the size
yeah,
alone.
yeah.
Yes, absolutely. I think what people who are viewing the CPC should do is go back to the first CPC and look at crypto and compare both of them. When you compare both of them, you'll definitely see the size difference. This is histo for sure, and also the huge number of them. I mean, crypto generally, I mean, I've never seen crypto. I mean, I've not seen that many cases, but even in textbooks, this team of the organisms, I think more favors histo, but I don't know. What do you think, sir? Is that a clue?
I think we shouldn't get confused with this histological picture. This is actually, I mean, we can be reasonably certain that this is histoplasmosis. We shouldn't bring in cryptococcosis into the differential of this histology. We can go back and look at the images of cryptococcosis. And as Dr. Sasi rightly mentioned, we do not see a sea of organisms in cryptococcosis. We see only a few, if any, and they are definitely larger. We need not actually discuss it as a differential diagnosis in this context. This is histoplasmosis. Any other organism that can resemble somewhat this?
So leishmania can be
Leishmaniasis.
because it is also
I think that is what we should discuss.
Absolutely.
Vinoth Kumar, how can we differentiate LD body from this
Actually, like
histoplasmosis?
kinetoplast, we can see some, but it's very difficult to see kinetoplast
Oh,
and leishmaniasis.
that is. I mean, we cannot depend on that finding.
Finding.
This pseudo capsule-like appearance helps, isn't it?
Yes.
That helps, and we can
Yes.
resort to histochemical stains. What histochemical stains can we do?
For leishmaniasis.
Yeah, I mean, for both to differentiate one from the other.
The like fungal stain we can histoplasm.
We can do. I mean, the PAS stain can be done.
Stain done. Yes.
Can be done. What about LD bodies? Anmol, what stain can we do? Demonstrate LD body.
Sir, I'm not aware of specific stains.
It is not. I won't tell that it is specific, but we can do GIMSA stain.
Yes.
Okay.
GIMSA will be, I mean, positive in for LD body.
LD bodies.
You can do a PAS stain for
histoplasmosis.
Histoplasmosis, and in the center of this this field, we can see the beautiful pseudocapsule appearance. This is histoplasmosis.
Yes.
Do not confuse yourself with cryptococcosis in this context.
Having said that, sir, for quiz purpose and given that most of them are juniors, maybe we should be giving marks to crypto and leishmania as well because.
Yeah, we can. I agree. That's what I said the first instance. We cannot be 100% certain based on morphology alone. That applies to most of the infectious organisms. You know, histopathology alone may not be 100%. We cannot.
Yes. Right. But such a sea of organisms, then we are thinking of either histo or leishmaniasis.
Yeah.
Crypto is less likely given the sea of organisms, right?
Yes.
Sir, can we differentiate between true and pseudo capsule just based on histology? I was also confused between that part in textbook.
This is actually a halo-like appearance around the organism. We are not seeing a true capsule.
I think that is difficult. I think I have to say that is difficult to differentiate. No, sir, on histology alone, I think difficult.
Yes.
Yeah. That capsule we can do stains. That's it, like for Cryptococcus.
Yes. We just have to
mostly in CSF and all.
Yes. But I think this cannot get more classical than this. I mean, it's a beautiful case.
Yeah.
So we have to thank Dr. Manoj Singh, sir, who has not joined the meeting, but I mean, it is as classical as you can get.
Yeah, people who have not seen histoplasmosis before, you know, this is how histology of histoplasmosis looks like. That should be the take-home message.
The beauty is you're not just, with the scan slide, you're not just seeing a single image. You'll be able to see the entire section and go back anytime you want and go to the website and look at the cases. For now, they're all free anyway. So please feel free. I mean, this is the excellent teaching case. Okay.
And both of you are discussing cases very well. You know, this is strictly an informal discussion. Both of you are doing extremely well. We are very happy with you.
Thank you.
No wonder you performed well in the quiz. Good, very good.
Right. They may be winning this one as well. We have to see, depending on. So histoplasmosis is 1 mark. Cryptococcus is 0.5, sir?
0.5, yeah.
Yes. Molluscum, no. Diffuse cutaneous leishmania is excellent. That is again 0.5 again.
0.5.
Cryptococcus is the same thing. Molluscoid pseudotumor, leishmaniasis is the same thing. So they're just synonyms there. Acanthamoebiasis, penicillosis. I don't think so. That is more. Is that not more hyphae? And I don't remember seeing a case. But what do you think, sir?
No, we cannot.
We cannot make a diagnosis. Coccidioidomycos again different, completely different. Post-calasal dermal leishmaniasis. Somebody has been very specific.
In PKDL, do we see so many organisms?
Yes, and also the history is not of PKDL, so I don't think we should be giving any marks at all.
Yeah.
I mean, this is a HIV patient. That is what I'm trying to simulate here. This is a HIV patient with weight loss and everything who's got diffuse cutaneous histoplasmosis. Okay. So we'll submit that. Then we move on to case number 6. Case number 6 and 7. We've got 2 more. Again, this is, I think, relatively easy. So is it? I can't remember who's taking this. Is it Dr. Vinoth?
Yes, sir.
Okay.
Sir, here in low power, I
Oh,
could
sorry. Let's
see
go to history. Sorry.
history.
So 15-year-old male presents with occasionally itchy lesions along the left leg, associated with pain in the left foot for 8 years, starting at 8 years of age. The condition initially presented as asymptomatic lesion on the left foot, gradually progressing upward to the left buttock. Has used topical steroids, salicylic acid, tacrolimus, a number of treatments, no history of trauma, similar complaints with family members. Obviously, none of these have worked. So that's the history. 15-year-old male, 8 years history, slowly progressive. By the history, it appears that it is a relatively linear lesion, right?
Yes, sir.
Okay, go ahead.
In the low power, I could see the hyperplasia, mostly like psoriasiform hyperplasia of the epidermis.
What about the stratum corneum?
Stratum corneum, I could see focal parakeratosis that is alternating, I'm thinking, mostly. And hypergranulosis is also there. Like in some areas, granular layer is like hypogranular.
We need not call this a psoriasiform hyperplasia because the acanthosis is pointed. We are not seeing the broad reterridges, isn't it?
Yes, sir.
I agree that it is regular in some areas and
Some areas.
fused reterridges are there. But the pointed nature of the reterridges, we should reserve the term psoriasiform hyperplasia when the acanthosis is regular and bulbous.
Okay.
So
Right?
I think, Dr. Vinoth, I think here you made a diagnosis and then you're trying to make up the histological findings accordingly. You don't need to do that actually because that will confuse I mean, it's okay to do it if you know the diagnosis, that's fine. But what happens is the viewers or learners will get confused because they will be looking at classical psoriasiform hyperplasia and looking at this case and they're thinking, how is this classical psoriasiform hyperplasia? It is not, You've already made a diagnosis in your mind because based on the history and everything, and now you're trying to fit it in. Don't need to do that. There's always ATP and the text and the lesions don't read textbooks, so we don't need to stick to the classical textbook description all the time. We just need to be free about our findings.
Yes. In low power, like in epidermal, I could see like hyperplasia, like and acanthosis, and then. Parakeratosis also focally I could able to see. And then towards this area, granular layer is like hypogranular and this like towards the right side, it's hypergranular.
Seeing some exocytosis.
Spongiosis, exocytosis, like.
See those cells? They're all lymphocytes, right? Whenever the spongiosis, there's bound to be exocytosis, right?
Exocytosis, yes, sir, yes. In that area it is.
Yeah. And then what about the interface then?
Interface, I could see like prominent blood vessel cell and like some inflammatory cells also there.
What about the basal cell there?
Degeneration, like vacuolar interface kind of.
Some amount of vacuolar interface change is there, I have to agree.
Yes, focally, but it's like in this area only focally.
Yes. So, what is the predominant pattern you would call this now? Is it psoriasiform, spongiotic, lichenoid? Which are you going towards?
I'm thinking of like psoriasiform. That's like the spongiosis is very focal in that one area. So
okay. Let me go here actually. What are we seeing here? Apart from blood vessels, you're seeing blood vessels. What are these pinkish structures?
Fibrosis, like dermal collagen is going vertically.
Vertically. What is that usually indicative of? If dermal collagen is going up vertically, what is it?
Lichen.
Chronic scratching.
Chronic pruritus, right?
Yes,
chronically pruritic condition can cause this. Okay,
This
so based on
vertical.
the histology alone, ignore the history. Based on the histology alone, if you were given this histological picture, what are your differentials? Top one differential, what is it? If you're only going to give one diagnosis, what is it? No history. This is the histological picture. Dr. Anmol, you can also give the diagnosis.
Sir, I would still favor ILVEN.
How can you favor Ilvin? I'm not even giving you history.
But sir, there is alternating ortho and parakeratosis in psoriasiform pattern and in psoriasis,
No,
classical
Dr.
psoriasis.
Nandakumar sir, I just told you it's not psoriasiform.
Psoriasiform.
Uh,
It is not
If
psoriasiform.
like
If you
inflammation,
say
like I can go
psoriasiform,
with
you'll be given negative marks.
okay.
lichen.
Lichen simplex chronicus, I would
Lichen
think of.
simplest, I can think of if it is not psoriasis because of the
That is what
dermal
I would think
collagen.
of. Maybe
Yeah.
Nandakumar sir will have a different answer. Let us see.
Yeah, no. I also feel that if you have to give one diagnosis, this is lichen simplex chronicus. The
Chronicus.
one clue that I could mention is that's why I asked you to mention this stratum corneum. This compact type of hyperkeratosis, no?
Keratosis.
Compact hyperkeratosis is not a feature of classical psoriasis, except psoriasis occurring in the palms and soles. Otherwise, we find only basket weave type of hyperkeratosis in classical lesions of psoriasis. But this type of compact hyperkeratosis with focal parakeratosis
Parakeratosis.
indicates more. I should use that adjective also, more towards a chronic eczematous condition. And then we are seeing the vertically oriented collagen, acanthosis, and the dilated capillaries and all. I would call it as lichen simplex chronicus, chronic eczematous dermatitis consistent with lichen simplex chronicus.
Absolutely, sir. I completely agree with you. Based on the history, I think they've come to a conclusion. So yes, I mean the based on the history, and let us go to the clinical pictures. The clinical pictures are classical. I don't think we need to go there even. So that's a linear lesion going up, and starting in the foot. There's also some nail involvement. Markedly hyperkeratotic, segmental lesions starting in the foot, going up the ankle, and it's a nice, beautiful case. Clinically, I don't think there's any doubt, and especially given the age. But if this was a maybe 50-year-old man who presents with this with a history of only for about 3 months, what is the differential? What is the diagnosis? I don't even call it differential. What is the diagnosis? Given the clinical history, if this was a 50-year-old man presenting with this lesion only for about a few months or maybe up to a year, it was not a congenital history. Any one of you would want to, Dr. Anmol, Dr. Vinoth, want to say what it might be given the histological picture? What would you then call it? And that is where clinico-pathological correlation comes in. Any ideas? Any suggestions? Maybe not you, Dr. Vinoth, because you don't know the clinical, but Dr. Anmol, you maybe have heard of this entity. No?
Go ahead.
Dr. Anmol?
We can make a guess, why not?
It is following a particular pattern, right? I'll give you a clue. What is it? What is the pattern it's following? What do you call that pattern, the clinically?
Sir, blascoidal,
Exactly. So what is the diagnosis?
blastitis.
Exactly. Adult blastitis. Adult blastitis would look exactly the same. Adult blastitis would look exactly the same, but it'll have a bit more spongiosis, may have it. But adult blastitis, it won't be that verrucous as this lesion is. But if that is a history, if it's an adult who's developed in the last few months or a year, that is a diagnosis. Okay. So why is this ILVEN? ILVEN is purely because of the history. I mean, the clinical pathological correlation is what ILVEN classically has psoriasiform hyperplasia, spongiosis, and parakeratosis. It's more inflamed. So inflammation would go with it. Spongiosis is very focal in this case, but that doesn't discount it. But the clinical is the steal, isn't it? Based on the clinical, you made a diagnosis of ILVEN, and then you've gone and appropriated the histology. But
and even if, I mean, in classical histology, we expect more of papillomatosis also, which is not seen here.
yes, sir, can see it. Yes, yes, yes. So it's a beautiful case for those who are learning, because it's an example of how we can be sidetracked. So by number of features, but then ILVEN is the spectrum of ILVEN is variable. So this is still within the spectrum of ILVEN. So just because it shows lichen simplex chronicus changes, you don't give a diagnosis of lichen simplex chronicus.
CPC is the
CPC is
key.
very important. CPC is very important. Okay. Do you both have any questions? Shall we go ahead with the answers, Dr. Anmol and Dr. Vinoth?
Sir, can we see this alternating hypo and hypergranulosis in lichen simplex chronicus?
I don't think that's specific, to be honest. Dr. Nandakumar, sir, what do you think?
I mean, mostly we see only hypergranulosis. We do not
Yes, sir.
find hypogranulosis.
But then we don't discount it based on that. It's not a hard clue.
Yeah.
Okay, so this is getting 1 mark. Lichen stratus is a nice, somebody has taught lichen stratus based on the clinical. So somebody says lichen stratus, what should be our answer? Dr. Vinoth?
Sir, I thought because of clinical history, I thought of ILVEN only, sir.
But why not lichen stratus based on the histology?
Lichen stratus can also be a linear lesion, no?
Yes.
Because we need to give them an answer. People who have put in that answer have got confused. So we need to tell them why it is not that.
What is absent here?
Lichenoid infiltrate.
Lichenoid
Yes,
infiltrate also. It's
and also,
focally I found lichenoid infiltrate also in this.
Yes, it's very focal. It's very focal. Lichen stratus can have both spongiosis and lichenoid interface change. So the epidermal changes itself do not discount lichen stratus. What should lichen stratus also have usually?
Is absent here.
It's deeper involvement. So lichen stratus usually also has deeper involvement. Eccrine glands. Usually there's a peri-eccrine infiltrate. Deeper inflammatory infiltrate is usually there in lichen stratus, and that's the usual differentiating feature.
It is considered as a mimicker. Lichen stratus, the histology of lichen stratus is considered as a mimicker. In fact, I have read one article also, lichen stratus, a chameleon. There is an article in which journal I forgot. But it can resemble psoriasis, it can resemble lichen planus sometimes. It can resemble spongiotic dermatitis. But the clue which Dr. Sasi mentioned, that is very important. Peri-eccrine lymphocytic infiltrate. Yes.
But it's very nice. I mean, it's good to discuss this because 6 people are confused. I think I think hopefully their doubts are clarified. But I don't think we're giving any marks for that.
We cannot. Unfortunately.
Neither are we giving linear psoriasis. Linear epidermal nevus is fine, but it's not a specific diagnosis. 0.5 for that, sir?
0.5.
Yes, can be given. Blastoid, linear acquired inflammatory skin eruption. So that's but the history is against it. So I don't think I'm going to give any marks because they've completely ignored the history there. For 15-year-old for 8 years, it's blastoid, but it's really a congenital ILVEN is a diagnosis. I don't think we can give anything for that. Or do you want to give 0.25, sir? Are you?
No, we cannot.
Okay. So the rest of them are completely.
Somebody has called it as lichen simplex chronicus, but unfortunately.
Okay. Yes, they got the histology right, but they missed the CPC.
Unfortunately, didn't do the CPC.
Yes, so no marks for that. I don't think so. Okay. So last case, either of you can volunteer because both of you have answered either equal number of cases, questions, but it's a very easy one. This one I think as well.
History.
I do here, sir.
So middle-aged male farmer, long-standing, slowly progressive verrucous plaque on the lower leg, mildly pruritic, occasionally crusted, no systemic symptoms. Very easy actually.
Yes, sir.
So, Dr. Anmol, you found something, I guess, you want to point out somewhere. So, let's go to the low part, but let's start systemically, though we know the answer. Let's start systemically. Okay. Go ahead.
So, sir, there is pseudoepitheliomatous hyperplasia pattern. So I was thinking of
Yes. Do you
chronic.
want to explain pseudoepitheliomatous hyperplasia? Because I'm sure a number of juniors may not know what pseudoepitheliomatous hyperplasia is.
So there is epidermal proliferation, there is a slight acanthosis, thickening, and the epidermis is going inwards toward the dermis in finger-like projections.
So we saw two different cases. We saw something that we called it acanthosis. Something we called it, in one case, we called it psoriasiform acanthosis. We
Yes.
called it irregular psoriasiform acanthosis. In one case, Dr. Nandakumar said, pointed out it's not acanthosis, it's epidermal proliferation. So how are you differentiating acanthosis, this epidermal proliferation, and pseudoepitheliomatous hyperplasia? Why is it pseudo?
Why is it pseudo?
And what is epitheliomatous? More importantly. Dr. Vinoth, you can jump in. You maybe know the answer.
Sir, it's like because of some underlying condition or like trauma that epithelial proliferation will happen. It looks like carcinomatous,
Yes,
but it's
epitheliomatous
not like.
basically means that it's a tumor of the epidermis, right? That is what
Yes.
epitheliomatous traditionally means. So you can see this infiltrative pattern. Can you not make out the epidermis seems to be infiltrating into the dermis? If you're looking at low part, it looks like an infiltrating epidermal tumor. Why not? Right? But then
Yes.
it's not really infiltrating because when you go higher power, the epidermis cells are normal. These are basically, it's due to the inflammation, the epidermis looks it's like it's infiltrating. So therefore, it's called pseudoepitheliomatous. That is all it is to it. A pseudo tumor. It looks like a pseudo malignancy. Okay. Dr. Anmol, you want to continue?
Yes, sir. There is dense dermal inflammatory filtrate, and to identify what it is, I will have to go a little higher power. I can see giant cells, so it is chronic granulomatous inflammatory infiltrate. There is lymphocytes and giant
So let's
cells and
start with the
lymphocytes.
epidermis, maybe. Start with the epidermis top and then let's go to the bottom.
Okay. So there is slight parakeratosis and epidermis is atrophied.
So compact, right?
I know
Compact. So Dr.
compact
Nandakumar sir
granules.
said earlier, we have to specify it. It's compact,
It's compact
uh,
parakeratosis.
yeah, hyperkeratosis and parakeratosis. Epidermis is pseudoepitheliomatous hyperplasia is already there. Then you want to mention, because you said pseudoepitheliomatous, then you have to already automatically mention that it looks normal, right?
Yeah, there is no ATP or
No ATP, yes.
features of
Okay.
malignancy.
So low power, you don't directly call it pseudoepitheliomatous because this could be epitheliomatous for all you know. So low power is just you say it looks like epitheliomatous hyperplasia. Once you go higher power, we can call it pseudo at that point. I know you because we've already made a diagnosis, it's easy to call it, but then when we're going systemically, this is the way. Yeah. Okay. Go ahead, please. Interface. What
Then
about the interface? Dermoepidermal interface.
so here the basement membrane is gone at places, but um, at rest of the places it seems to be maintained.
I think it's fairly
It's man
it's
maintained.
fairly
That's
destroyed throughout.
very
Don't you agree? You can even see sawtoothing to some extent of the retiges. Can you not see that? Yeah.
yes, sir.
What is this type of infiltrate called? It's there's a particular name to this. What do I say? This histological pattern. What is the pattern reaction called? Even low power, when you're seeing granulomatous infiltrate.
Lycanode and granulomatous.
Yes, lycra and granulomatous. And immediately you're thinking, when you're seeing lycra and granulomatous, you're thinking what?
Mm, the chronic infections and
Chronic infections, particularly any specific infections can usually associate with lycra and granulomatous that come to your mind.
syphilis. Not,
Syphilis
yes.
is not
No, no,
usually
no. I
okay.
Yeah, I'm confusing a little bit, sir.
Go ahead. Don't worry. Just tell whatever you feel, whatever
So I was
comes to your
thinking
mind.
of deep fungal infections. They are usually associated with the lycanroid and granulomatous.
Yes, yes. What about anything in the mycobacterial spectrum? Lupus vulgaris, right? Lupus vulgaris also associated with
Yes, sir.
lycra and
Lupus vulgaris
granulomatous,
also
though there are
there.
much more well-defined granulomas there and caseation necrosis. Lycra and granulomatous. And then you're seeing something else here. What are these cells?
Neutrophils.
Yes, so lichenoid granulomatous and one more qualification now.
Neutrophilic abscess.
Suppurative, exactly. So lichenoid granulomatous suppurative almost virtually rules out lupus vulgaris because usually neutrophils are absent in that entity. So when you're saying neutrophils, lichenoid granulomatous, you're thinking automatically deep mycosis would be my top this thing. And then when you go deep, I think you've got a diagnosis here, right?
Yes.
What
So
is
there
what are you
are
seeing?
medullary bodies or copper penny bodies
Yeah,
or
absolutely.
chromoblastoma.
Absolutely. Beautiful textbook case. If anybody has not seen one, go and see it 100 times.
What,
Not
what,
going to miss it.
what is the reason for this brown color of the copper penny bodies? Why are they brown in color?
So because of this, it produces pigment.
Melanin. It produces melanin
Melanin.
pigment,
Yeah.
right? And
Yes.
any differential diagnosis for this lesion? What can look like? I mean, what other condition can look like chromoblastomycosis? Vinoth Kumar, how will you differentiate pheohyphomycosis from chromoblastomycosis?
So these are sometimes they are present in cluster of coin appearance and they can be central septa in these copper penny bodies.
In
Septation.
pheohyphomycosis, we find hyphae, whereas in
Hyphae.
chromoblastomycosis, no hyphal structures will not be seen, right?
Yes.
And another question, for the exam, it's a catch question. What special stain you will do to confirm it is chromoblastomycosis? Will you do any special stain? Yes or no?
Sir, that stain for melanin, Fontana Mason Fontana.
So you would like to confirm whether it is melanin or not. But if your answer is a fungal stain,
Then we can give GMS.
that is a wrong answer. Actually, you shouldn't do a fungal stain in this context. It will mask the color of the
color of
tumours,
the
right?
pigment.
So we are not supposed to do a PAS stain or GMS in this context.
Yes, sir, we should prefer melanin.
Yeah. So this is chromoblastomycosis. Beautiful slide. And the immediate DD should be pheohyphomycosis. We are seeing larger and larger number of pheohyphomycosis cases these days because of lot of people who are on immunosuppressants and all develop pheohyphomycosis, right? So look for presence of hyphal structures also. Here the epidermal changes are very characteristic. It is in favor of chromoblastomycosis, right?
One of the, clues as well, learning points is if you're looking for these, copper penny bodies, look for the neutrophils and look at the area where there are more neutrophils. Here it's interesting because it's present within a giant cell. Beautiful image. Can't get more beautiful than that. Nice case. Again, this is all these are.
And these can actually sometimes undergo transepidermal elimination also. So these bodies can sometimes be seen within the epidermis also.
I think they are there. I thought I saw them somewhere.
Yes. That is by way of transepidermal elimination.
Yes. Excellent. So case number 7, 9:35. We can quickly close this here by answering. So 25 out of 33 people got it right. Excellent. Tuberculosis verrucocutis, one more differential we didn't discuss. Very good differential if you're not seeing the copper penny bodies.
Yeah.
I don't think that we can give any marks to anything else. Chromomycosis. Okay. I guess I didn't realize that's in there. Are we giving that marks, sir? I guess.
Mycos, we can give marks for that.
The same thing. So I didn't realize that's in there, but that's fine. Actinomycetic mystoma, cutaneous tuberculosis. No.
With so many copper penny bodies, how can you miss it and call it as cutaneous tuberculosis?
Yes,
No
maybe
excuse for that.
somebody didn't see the thing properly. Okay. So let's see who. Oh, it's not yet computed. So let it compute, and I'll announce the results maybe on the website and the groups later on. So yes, any what is the experience, Dr. Anmol and Dr. Vinod? Any questions, any doubts still that you have?
No, sir, it's actually very nice. Like, this is my first time attending this. Like, it's a good learning for me.
Excellent. So keep winning. We'll invite you again, and please tell your colleagues as well to join the meeting,
Yeah.
see the meeting,
Yes, sir.
and
Sure,
join
sir.
the cases, because we are here to teach. We like if
Yes.
more people come and attend, because this is just a we love to teach, and that's why we're doing it. So it's a free service. So yeah, please do make use of the service. Dr. Anmol?
Yes, it was an excellent opportunity for me. It was also my first time as being a resident in a type of a discussion like this. And I also have special interest in dermatopathology. That's why I'm following this. And I think
Excellent.
my teacher will be proud of me. I was
Oh, we are proud
taught
of you as
only,
well, actually.
yes,
Both of you.
Yeah, as I said, it was we enjoyed having both of you. You performed very well, and
yes,
Thank you, sir.
But that is not to deter future participants who want to participate. This is a very informal meeting. And please do participate and win, and we'll get you into the panel. And it's a good drill. I mean, it's better than sitting and watching the session, right, Dr. Anmol? If you're in the panel and you're able to ask questions and everything,
yes,
I think that's very
sometimes we
useful.
have some silly doubts which we cannot ask. Otherwise, only if
Absolutely.
we are on the panel that we
No,
can ask.
actually, no doubt is silly. I mean, let me correct that. No doubt is silly at all,
Yes,
because every doubt needs to be clarified. And in fact, go through all the sections and make sure that you're able to identify everything in each part of the section. Because if you're not sure about something and you think, okay, I know the diagnosis anyway, let me skip this. Next time you see that in another condition, you won't know, oh, I should have learned what that is. That may be normal skin, that may be a special finding. I didn't actually, that was an incidental finding in something else, and you missed it when it was actually a pathognomic finding in the actual case. So, and there are artifacts that we may sometimes think that, oh, we don't know what it is, and then you see the artifact in another case that is the only finding, and you may think, oh, this is some pathology, I know what it is, I don't know, I should have asked somebody. So we need to go through the entire section and make sure that we know each and every thing that we are seeing. We should be able to identify everything that is there in the section. Dr. Nandakumar, sir, closing remarks before we finish?
yeah, please encourage your colleagues and co-PGs to join the
Sure, sir.
program, right?
sure, sir.
Okay, thanks.
That's the side. Yeah.
Thank you, Glodama team, for hosting us, and we'll come back with the next date by the end of this month. We'll announce the next date, and thank you, Glodama team. Thank you all.
Yes, sir. Thank you so much. Thank you, everyone.
Good night. Good night.
Good night.
Good night.
Good night.